And thank you so much for joining us this evening for our 2022 Community Health Education Series. My name is Ivania Covington, and I am the Community Partnership Coordinator for Faith-Based Partnerships and Senior Strategies here in the Social Responsibility Department at Baptist Health. Tonight, our topic is stroke awareness because May is National Stroke Awareness Month. We have a special guest speaker tonight who I will be introducing in just a moment. But first, I would like to go over a few agenda items. So first, I will go over some housekeeping items. We will have then the presentation in the Q&A with the speaker. And finally, I will end with some brief closing announcements. So as far as our housekeeping items go, there are just three that I need to go over. So first, tonight, we will be recording tonight's session, and it will be made available to all of our registrants tonight. Secondly, we are tracking attendance. So if you have invited others to view with you who did not have an opportunity to register for tonight's session, first we say thank you so much for spreading the word and inviting others to view with you. We just ask that you add their names to the chat, or if you can just document the number of people viewing with you tonight in the chat, we can document that for our attendance records. And thirdly, my director, Ms. Lynn Sherman, will be monitoring the chat during the presentation. So feel free to type your questions there, and they will be addressed during the Q&A segment. So without further ado, I would like to introduce our speaker for the evening. Ms. Cheryl Lewis is an advanced registered nurse practitioner with a 40-year career in acute care. She has received national certifications in both critical care and stroke. She began at Baptist in 2009 as an advanced practice partner in the Heart Hospital and has been a stroke coordinator for Baptist Health since 2014. Cheryl currently oversees the stroke programs for the following Baptist locations: our downtown, Nassau, and Clay County hospitals, as well as the North Oakleaf and Town Center sites. So Cheryl, thank you so much for being here with us tonight. And if you want to go ahead and begin to share your screen, I'll stop sharing mine. And you can begin when you are ready. I think you're muted. You have to unmute yourself.
All right, can you hear me now?
I can hear you just fine.
Okay, let me bring up the PowerPoint and we will get going. I appreciate the opportunity to be able to speak with everyone tonight. And we're going to talk about stroke, as Ivania said, and hopefully we can learn some new things or decrease our risk factors so that I don't have to see at any of our hospitals, everybody that's out there. All right, so we do call stroke brain attack. And this reminds me of a 1950s movie that my partner made this first screen. But we were trying to get the impression that stroke is something to be afraid of. And that's where we have a lot of problems with people not coming to the hospital because they feel that, that nothing can be done for stroke. And we're going to talk about what has changed over the last 20 or 30 years. I would like to tell everyone that all our facilities are Joint Commission certified. That's a very high standard that we carry for stroke. Our Jacksonville campus, which is the largest campus, is comprehensive stroke center. Beaches campus is a primary stroke as well as South campus. And then Nassau, Clay, Town Center, and Dunn, Clay will soon be a hospital, are all called acute stroke ready hospitals. So the surgeons that we're going to discuss what they can do to help with thrombectomy live down at our Jacksonville campus. So you might end up visiting one of our other campuses and have to be taken to Jacksonville, and that's completely acceptable. That's where these guys live, and that's where they would operate on you to make sure that everything goes well. Otherwise, we can help our patients at Beaches South and our other facilities by giving the clot buster drug and keeping patients there so that they don't have to travel out of their comfort zone if something does happen, all right? So in 2020, and I apologize, we don't have the 21 numbers, but in 2020, you can see that we treated over 2,000 stroke patients in the Jacksonville and surrounding areas. The clot buster drug, which we call Altaplace, it was given 156 times with very good results on those patients. the OR cases, which include thrombectomies and aneurysm repair, you can see we approach almost 200 thrombectomy cases a year. This is where we go in and pull the clot out of their brain, like people when they had heart attacks, and we now go in and pull the clots out of their heart. We can do that in people's brains as well, and we'll look at some slides about that. Aneurysm repair is kind of sneaks up on you sometimes. There are people that have aneurysm in their family histories. They might know what I'm talking about. In the brain, when they rupture, that becomes a brain bleed, and we have to go in and help. Can we stop the bleeding? Do we need to do some other type of surgery to help that patient? So we have a very robust program. It is the largest program in the area, due to the fact too that we have so many hospitals that treat these patients. All right, we do have our community commitment, incorporating the latest scientific evidence and clinical practice to lead the region in the prevention, recognition, treatment, management, and rehabilitation of our community affected by stroke. And this is what we live by. We want to help our community and the people in it to make sure that they can lead a prosperous life. So when we talk about stroke, we talk about the 3 R's when we talk to the public about stroke. We want to reduce your stroke risk. We want to recognize stroke symptoms, or teach you to recognize stroke symptoms. And we want you to respond. And the response is the biggest thing when you're on the outside, calling 911. Because about 80% of all strokes are preventable if we just follow these simple 3 R's. So a definition of stroke for our family members that aren't medical out there is the proper definition is lack of blood flow to the brain caused by a clot or rupture of a vessel. So a clot can be cholesterol, it can be a blood clot, it can be a little piece of something that broke off in the brain and it's clogging up that vessel, and now it's decreased the blood flow to that area. The hemorrhage or brain bleed, I talked about with aneurysm. When an aneurysm ruptures, it's a little bubble on the side here. It bleeds freely into the brain. And we want to stop that bleeding to decrease the cause of, any tissue that might die from that. Both of these, though, are considered stroke. It's not just one is, called stroke and one is not. They're both considerations for stroke. A TIA, there might be some people out there that have been diagnosed with TIA or know about TIA. And this is a transient ischemic attack. Now, if people have had a TIA, it is one of the only warning signs that's going to tell you that you're prone to be having a larger stroke at some point. And the statistics currently on this are more than 1/3 of TIA patients, 5% will have a stroke in the next 2 days, and 10% will have a stroke in the next 3 months. And we've seen this play out in our hospitals when we talk to patients. Did they have previous symptoms? Did you go to a doctor? Were you being seen for something else? Do you have TIA in your history? So we can judge a little bit of when a stroke might happen, but it is kind of nobody has that crystal ball to look at it and tell everybody. But that's why we have to take care of ourselves. And we'll talk about the risk factors in a minute. We do call stroke a brain attack. We tried to catch on like heart attack caught on, but people just call it stroke still. And we're perfectly happy with that verbiage as long as you come to the hospital and see us. Doesn't matter what you call it. So let's talk about some stroke facts for the country. Stroke is the 5th leading cause of death in the United States. Stroke is the leading cause of disability in the United States for people under the age of 65. So when we look at people that have large strokes that can't return home, if I would have a large stroke, I'm now 59 and a half, coming up on 60. My children are younger. I had them when I was, 40. So you can do the math. I was a little late bloomer there. They still couldn't take care of me if I had a large enough stroke. I would have to go into a nursing home to be cared for. And that's part of what we're trying to prevent, is that people have these devastating disabilities where they can't take care of themselves. And then the family is in the circle of having to pay the nursing home to take care of them or pay for the insurance to take care of them. And everybody has to get a job, previously when maybe they didn't work and had to take care of them. So we want to decrease that disability. What we have, I want everybody to recognize here is we do live in the stroke belt. So these are called heat maps. And these maps tell us, they're epidemiology maps that are put out by the Medical Association and talk about where pockets of hypertension, diabetes, and smoking might be. For us, why we say we live in the stroke belt, when you see this deep red here, it starts over here in Florida in pretty much all this area for the white population and then into the Black population as well. This starts the stroke area and it comes across to the west. So some of this is in ethnicity, some of this is habits. People still smoke as we get further out into the rural areas. I still find people smoking, which is the #1 cause. If you decrease that right now, you probably won't have a stroke. It'll be, something else that affects you. But diabetes, we know that's a big factor, especially with the obesity rates changing in the United States and going up. So any of these problems, smoking, diabetes, and hypertension, show us where our big problems are. Diabetes in the Black population, you can see Florida is right up the whole coastline, is involved with that. Smoking in the Black population, not so much through the South, but we see it through the North with that. But it is enough data there to show us that we are in the stroke belt. Now, you may have heard of some people that have had stroke. Paul Levi Robeson, who was a singer and civil rights activist, Della Reese, Kirk Douglas, and 2 of these people had strokes in their later years. We know Kirk Douglas had his stroke in his 90s. Stroke is a disease of old age, but it can be, you can put it off for many, many years if you're living right otherwise. Della Reese was also older when she had her stroke. Other people who've had strokes, 2 of our past presidents, Gerald Ford and Richard Nixon. Sharon Stone was actually quite young. She actually had an aneurysm that ruptured. She had a brain bleed and survived that at a very young age. Let's see, who else? Charles Dickens. So stroke care goes way back, as we know, when the time period when Charles Dickens lived. Charles Schultz recently died of stroke in the last several years. Roy, Horn, and Siegfried, the entertainers in Vegas who had the white tigers. Now, Roy had a different type of stroke. I don't know if many of you remember, he was attacked by one of his tigers on stage. And unfortunately, the tiger got to where his major arteries were and bit into it. So he was losing blood. When the brain loses blood as well as something clotting off the blood supply, you will have a stroke in the brain as well. So he had a little different type of stroke, but it still gave the same, unfortunately, debilitating problems as stroke does. Luke Perry, a very young stroke patient, I think he was in his 50s in the last couple of years, had a stroke, which was unexpected. I believe, having read his lifestyle, that it was not a normal thing in his family. Stroke risk factors that we can't change, and this is something we have to live with. This is why we have to be good on the other side. Our age, after age 55, your stroke risk doubles every 10 years. So I'm over that 55. I have that as a risk factor. Gender, I will tell you that males have bigger strokes than females, but more females die of stroke. And we'll talk more about that in a minute. Heredity and race, we have the African Americans have the highest incidence of stroke. Behind them, the Asian population, the Middle Eastern population, which I'm part of, and the Latino population, which is now a rising population in the United States, have a high risk of stroke in their family histories. And then family history or prior history of stroke. These are things you cannot change. You can't change your parents. You can't change your age. I wish I could every day, but that's not working. So we just have to be good with our other risk factors. Now let's talk about some of our other risk factors. We have the #1 risk factor is high blood pressure, and keeping our blood pressure, if you're on medication, sustained at under 140/80. Our weight, controlling the weight and making sure that we, kind of don't tip those scales when we go to the doctor's office. Lack of exercise. Sleep apnea has become a huge player for the stroke population. And we find out that what happens in sleep apnea is that one day and I've seen many patients like this, the patients will come in with a stroke complaint. And when we do the MRIs or the CTs, it looks like they've had multiple strokes. But what happens is with sleep apnea, when you stop breathing in your sleep, every time you do that, a little piece of your brain, a small piece, dies off because it's not getting oxygen to your brain. So by the time we see these patients, it looks like they've had a larger stroke but it's actually happened over the years because of the sleep apnea. Heavy alcohol use and drug use, smoking we mentioned already. Smoking, if we would stop today, if you're smoking, your stroke risk drops by half. And within a year's time, your stroke risk is negligible to other processes, you know, if you're obese or hypertensive or things like that, the stroke risk goes away from smoking. Diabetes, making sure that we monitor our sugar if we are diabetic, a proper diet, exercise. Cardiovascular disease, atrial fibrillation has become a big issue for the stroke side. And if you do have atrial fib or intermittent atrial fib, meaning your heart does it kind of off and on and we can't really judge it, we have you on medication, unfortunately, you're still at a higher risk of stroke and we need you to take the medication we put you on. Usually that's treated with blood thinners. I'm sure some people are familiar with that. And then we have high cholesterol. Now this could be diet induced or it could be genetic. But either way, we need to control that. And we have medications for people with high cholesterol. All right, let's talk about African Americans with stroke. With stroke, we have a 40% higher rate than the Caucasian population. We are twice as likely to die from stroke and have more disability. They do have larger strokes, and this is just from practice as well as research. And we do have a higher incidence of hypertension, diabetes, obesity, smoking, and sickle cell, which can cause little clots, microclots that go to the brain and can cause stroke as well. So these factors, two or three of these are easy to control with medication, but you have to take the medication. Asian population, again, more likely than Caucasians to have a stroke. They do have large strokes as well with worse recovery. And only about 20% have hypertension, but it is one of their leading risk factors for stroke that they have to monitor. And then we have the Hispanic population. As I mentioned before, we have an upcoming Hispanic population in the United States. And even in Jacksonville, we are seeing a higher number of Latino people having strokes at a younger age. So it really is prevalent in their ethnic background. Sometimes problems we have with people that come in, especially the Asian population or the Hispanic population, is we cannot articulate, or they cannot articulate what is really happening to them. So we see delays every once in a while in care, but we have interpreters at all our hospitals in Jacksonville. If we don't have them on site, we have them by the iPads that we use, and they can get an interpreter almost immediately on the iPad and help us to figure out what they're trying to tell us. And we've done that with several patients to help with their care to make sure that they're treated very quickly. Women in stroke. So let's talk about women. I talked about earlier how men have larger strokes, but more women die of stroke. And stroke actually kills more than twice as many women as breast cancer does. Breast cancer, I believe the latest numbers I saw, the mortality rate is around 50,000 per year, which means about 100,000 women die of stroke per year. And a lot of times this happens because we do everything for the family, right? We have to go pick up the kids. We have to make the lunches. We have to do the laundry. In my house, I have to wash the dog. I have to feed the dog because the poor dog would starve. But if something was going on, I'm going to do all that before I then go to the hospital. And I have seen this many times when I speak to women, especially women in their 40s and 50s who are having strokes. They had other things to do except come to the hospital, and that can be very detrimental to patients. So we always like to try and get that word out that you need to come to the hospital when the symptoms start, or when someone notices that something is wrong, just come straight to the hospital and worry about the rest of the stuff later. Now, one of the, for the younger women, and I don't know who's in the audience tonight, but women who are around the age of 30 who still smoke and are taking oral contraceptives, and this can go for smokers and hormone replacement therapy or postmenopausal women, have a very high risk of stroke because that creates its own clots in the body. So the smoking causes problems. We know that it can cause constriction in blood vessels, the nicotine and other chemicals that are in cigarettes now, or vaping is one of the worst ones you can do. And the contraceptives or the oral hormones also create clots as well. So we do see younger women having strokes that are still smoking. Now, I will tell you that the hormone replacement is not just limited to women. Men who are taking testosterone and still smoking, I have seen one stroke from that in the last couple of years, because testosterone replacement is becoming popular for men, just as hormone replacement was popular for women postmenopausal as well. So we have to be careful with those drugs. And once you have a stroke, you can't take those medications anymore. Really, you should stop smoking. That's the only way that you're not going to have another stroke, because there's a high risk of secondary stroke if you continue your habits like that. Other symptoms in women, because we can have very odd symptoms. It's the same as in chest pain, very odd symptoms compared to men. The largest studies, I'm going to refer to heart patients for a minute. The largest studies done for chest pain were done in men age 40 to 60 in the 1980s. I think most people would know the Framingham studies. They left women out completely. It wasn't until I started practicing, I was in the 80s, probably in the 90s, we started saying that women actually had different symptoms for heart attack than men. It is the same with stroke. It has taken us several years to figure out that women do not have the same symptoms as men. That doesn't mean that we're not going to have the big symptoms of loss of use of one side or vision or things like that. But when you look at this list, you can see that we can have fainting all of a sudden, general weakness, general malaise. A lot of times when you talk to women who are either having a stroke or heart attack, they just say they just can't move. They're very weak. They don't know what's wrong with them. And then we have to kind of sort it out from there. They could have shortness of breath. And some of that has been a problem with the COVID as well, because that number one symptom of that was shortness of breath. Confusion, unresponsiveness, or disorientation. Behavioral changes, that could be confusion as well, or agitation. All these are mental problems that when you're not getting the proper blood supply to your brain, or one part of your brain has been clotted off, you're not going to act right. Hallucinations, nausea and vomiting is very prevalent in women. We see that more so with dizziness, nausea, and vomiting. Those are the three symptoms that I see a lot when our women patients come in. Possible pain, and it could be just generalized pain. Seizures, people that have strokes do have seizures, a small percentage, and that kind of starts our process. And then unexplained hiccups, or hiccups that won't go away. Now, that's a very peculiar symptom, but it is quite true with stroke. When we see patients that they come in complaining about they can't stop hiccuping, and we see probably one a year that has this symptom, believe me, we're looking on the neuro side. What is making them hiccup? What nerve ending is not working correctly? So very odd symptoms for women. And that's why it's important that if you're not feeling right, you need to come to the hospital. Again, why do patients not come to the hospital? Well, they don't recognize their symptoms. They think that nothing is going on, right? That I talked about, we might have other things to do. Maybe they think nothing can be done. They worry about the cost. They think the symptoms will disappear. And some people truly fear hospitals. I've had several patients over the years that unfortunately were treated as children. And because of that, of how things went, in their childhood, they were terrified of hospitals. Like every time you walked in the room, their blood pressure went up. But we're trying to get the word out that, we're not that bad. We're trying to help everyone. All right, so what are some of the warning signs of stroke, some of the symptoms you see? Well, it does depend on where your stroke is. And I'm not going to spend a lot of time here because we could spend a whole conversation just about talking about this. But I have a different slide here. So if we have a stroke on the left side of our brain, we can show right-sided weakness. We might not be able to feel on the right side. We might not be able to see on the left side. The eyes may shift to the left, or you might not be able to talk because your left side of your brain controls your speech. It also controls your mathematical ability and how to strategize is the best way to talk about it, or the logical part. When we talk about people that are confused, their logic is gone. So that's the left side of your brain. On the right side of your brain, this again, you're going to have left-sided weakness. It always crosses the body. Left sensory loss. You might not be able to feel something in your hand. We do get that complaint. My hand won't work right. Left side of the vision is gone. Right-sided gaze, meaning you're looking at your right side. You cannot move your eyes. And neglect. Neglect is when, like if you were having breakfast in the morning and someone set us up a cup of coffee next to you, and all of a sudden you just knocked it off, and your wife looks at you and goes, "What'd you do that for?" And you say, "Well, there's nothing there." That's neglect. That means you didn't even realize there was a cup of coffee next to you. And we do see that with couples coming in, and that's a big clue to us that that's a stroke. Your right brain also is your creative side. So when someone has a right-sided stroke or right brain stroke, they sometimes can lose that artistic ability or the color, being able to use color properly or see vivid colors, things like that. So there's a lot that goes on in the brain on both sides. All right, one of the easiest ways we teach people to recognize stroke is called BEFAST. And some of you may have heard about this by now, especially if, unfortunately, if you've been in one of our hospitals. This is what we teach the family members so that they know how to recognize a stroke, or if more stroke symptoms have come on, their loved one when they're home. The B is for balance. So if you have someone that gets up and then all of a sudden their left leg gets out and they can't stand up straight, or when they go to walk, they keep going to one side or they keep falling to one side, that's a sign of stroke. E is for eyes, and the eyes can be several things. It can be blurred vision, double vision, or loss of vision. There are very few things that I can think of besides the low blood sugar that might, disturb your vision that much where I wouldn't think it was a stroke. Any of those symptoms need to come to the ER immediately, because in this town, in Jacksonville and the surrounding area, if we lose our vision, we might not be able to drive anymore, and you can't get around. This is one of the largest counties in the United States, so it's very difficult to get around when you can't see properly. And sometimes blurred vision does not go away after stroke, so we want to be very careful of that. F is for face. Does the face look uneven? Does the mouth droop, or the eyelid, one side of the eyelid drooping that it wasn't before? That's an immediate sign of stroke. The arms, A is for arms. Can they hold, I was talking about the coffee cup, can they hold the coffee cup in their hand, or where they kept dropping it? Or is it drooping completely? Can they not raise their arm up or their leg up completely to move it to walk or, properly hold themselves up? And then S is speech. And this could be slurred speech, trouble talking, garbled speech, or no speech at all. We've had patients that they couldn't answer their spouse when they were asking them a question, and luckily they brought them immediately to the hospital, because that is a sign of stroke. And then T is always time. We want you to call 911. I know in a lot of our areas, people live around the hospitals that I work in, and they have a tendency to drive themselves. However, that cannot be such a good idea. One, rescue is there to help you. And rescue has been taught our protocols, and this goes for any stroke program in the city. If you call them and tell them you think you're having a stroke, they call ahead to the hospital so that the team can meet you when you come off the ambulance, and we go straight to CT or CAT scan. So we always want people to call 911. I know it seems like a lifetime for them to get there, but believe me, they are there very fast in several minutes. All right, so let's talk about the treatments of stroke. We have the clot buster drug that I had talked about earlier. We call it Alteplase or TPA. And then the endovascular devices where the surgeons go in and actually can pull out the clot or chew it up and then suck it out. And then the brain bleeds that I talked about with the aneurysm, we have something called clipping or coiling. And that's where we put all these little microscopic, they're about the size of a hair, coils in the bubble that's on the blood vessel to clot it off, so that it can't rupture and cannot cause damage to the person. This is a very nice shot. So this is one of our patients we've had over the years. There should be, well, let me give you some reference points here. These are your teeth coming up here. You're coming up through the carotid. We do start at the groin and we work our way up. And these catheters are very skinny, as you can imagine, because we're going up into some very small vessels. Now, in this shot, there should be a lot of spider webs here, what I call spider webs or blood vessels showing on this patient. The stroke has clotted off this area right here. And when we took the clot out, you can see how much we got back for this patient. That's about half their brain right there would have been gone if we hadn't gotten to that patient in time. The next picture is the actual clot that we took out. Now, this is in centimeters, but 3 centimeters is equivalent to about 2 inches. So sometimes we make great big clots by ourselves for no particular reason, but then, sometimes there is a reason. We smoke, we don't take care of ourselves. Maybe our diabetes is out of whack, something like that. So we pulled this out, and that one actually walked off the table. They were very happy. Excuse me. So again, 80% of stroke can be prevented if we do what we're supposed to do. And I want to recap what we've learned so far. We want to know what your blood pressure is. If you go to a primary care doctor and his techs don't check your blood pressure when you first walk in the door to see him, you need to find a new primary care, because this is standard of care in all our practices at Baptist. As far as I know, Baptist owns, I believe, about 200 private practices now. We've spread out throughout the city, and they are all within our network to help our patients, meaning too that they can see what's happened in the hospital if you are in the hospital, or we can see what's happened in the office. If patients come in too, we can ask for those records very quickly now. But checking your blood pressure, making sure, again, it's under 140/80. That is the current standard for heart and stroke care. If you're diabetic, making sure you're doing your medications, you're checking your blood sugars, not just once a week, but once or twice a day or 4 times a day. Depends on how bad a diabetic you are and what medications you're on as to how often you check. If you smoke, you got to stop. There's no way around that one. And the vaping I mentioned earlier is worse than smoking at this point. And I talk about this so that you can let your children know, because I had teenagers at one point when vaping was becoming big. And one of the brands, I think it's off the market now, but there are so many and they're not FDA regulated. One puff of the vape was equivalent to 3 cigarettes. So that's a huge amount of nicotine going into your system, as well as other chemicals. We know about the chemical problems with vaping, children that had to receive lung transplants and that. But we gotta, talk to your kids or talk to whoever in your family is vaping and smoking and try and get them help or to stop. And then atrial fib, if you have atrial fib, now this can be kind of hard, especially if you're undiagnosed. If you're feeling a racing in your heart, if you're having shortness of breath and having like your heart is racing, those symptoms together, dizziness on a regular basis, you do need to be seen. Go to your primary care. He might refer you to a cardiologist who will do some tests or an EKG. And I know some primary cares can do EKGs in the office, but if they think it's atrial fib, they're going to send you to the ER, because we need to get you out of atrial fib so that you don't make little clots that, can cause stroke when that happens. High cholesterol, again, we talked about, you have to take your medicine. There's a common theme here. You got to take your medicine. Atrial fib as well, they're probably going to put you on medicine, so you need to take your medicine. And then alcohol in moderation. So the current standards for what we consider moderation is 1 alcoholic drink. I think it's less than 1 ounce for women and 2 ounces for men, and not even per day, every couple of days or so. It's nothing you can do on a regular basis. And I think we know, most adults know how bad alcohol can be on your body if you're doing it regularly. Exercise, number 7. Do you have a daily routine? And I will tell you, the current standard from the American Heart Association is nothing stringent. It's not going and running 10 miles every day or things like that. We just want you to walk 30 minutes one way, 15 minutes one way and 15 minutes back. If you have a good neighborhood or an area where you can walk in. When you go to the mall, sometimes you see the people in the morning that are what we call mall walkers. The Avenues is one of the only ones I think that's still open all the way. And that is a mile, I want to say 1.5 miles to 2 miles, all the way up one end and down the other. And it's air conditioned. It's one of the only places like that now where you can do that and beat the heat. You don't have to worry about the heat if you're outside walking. Low sodium or low salt diet and lower in animal fats. What we consider the Mediterranean diet, a good diet to follow. It uses olive oil. There are people that like coconut oil better, very similar properties, but not too much red meat. Red meat, unfortunately, maybe once a week or less, once every 2 weeks, more fish and chicken and vegetables. And then find a way to reduce stress in your life. This is always the hardest one. Anyone with children knows this, because you always worry about things. And if you work, you worry about things, but you have to find an outlet to help yourself relax and reduce the stress that's going on in your life. as we know, there are many studies out there that talk about stress and how detrimental it can be, even if you're trying to do everything else to your blood pressure and, what can happen if you continue high stress in your life. And then again, if you think you're having a stroke or see someone that's having a stroke or symptoms that we've talked about, call 911 and bring them to get them get rescued, to bring them to an ER to be evaluated for stroke. And if you recognize that, tell rescue you think it's a stroke, because sometimes they get a little off track too. They get wrapped up in all the other symptoms and they don't see the big picture. So if you know someone is having a stroke, tell them that. That's okay. It's not going to hurt anybody's feelings. All right, so we've talked about a few things tonight. Some of the myths that hopefully we've dispelled. Stroke is not preventable. It is preventable up to 80%. It can be treated regularly. We have emergency protocols, and like I said, all Baptist hospitals and every hospital in the city is stroke certified that I'm aware of currently, because we are in contact with the other stroke coordinators for the other hospitals that I recognize. Not everyone can come to Baptist. We just want you to get treatment. Anyone can have a stroke. I've talked about some of our younger patients. We've had patients who have unfortunately delivered children and then had a stroke, because that can be what we call a hypercoagulable event for a woman to have children. Stroke is a brain attack, and stroke recovery doesn't end after 6 months. It is a lifetime recovery, and I know that can be difficult for patients. We do have psychologists that can help us to see patients in our hospitals, and then we can give referrals when patients leave the hospital, because depression is very real for stroke care as well. So we want to help our patients even when they're gone from the hospital. All right, so how do we reduce our impact of stroke? Our 3 R's again: reduce our risk, recognize the stroke symptoms. We use BEFAST. Respond immediately, call 911, because every minute counts in stroke. Okay. And we've talked about a little bit about all of these already. Risk factors can reduce the odds of experiencing a stroke. Earlier treatment does lead to better outcomes. The faster you get to the hospital, the faster we can help you. And Baptist does have a very experienced team working, through the community hospitals and our main hospital at Jack's campus to help treat those stroke patients coming in, whether they're ischemic or hemorrhagic. And we do have a new hospital opening. I don't know if any of you are in the Clay area. The current ER there, the Baptist Clay ER, is converting to the hospital. It's supposed to open November of 22. So there will be 5 Baptist hospitals to go to, and that'll leave us 3 freestanding ERs too that all have stroke protocols. Okay, and that's it. I thank everyone for their attention tonight, and if you have any questions, I'll be happy to answer them as best I can.
Thank you, Cheryl. Thank you very much for this very thorough presentation. I learned a lot. I learned a lot, and I'm sure that our audience also learned a lot as well. We have 2 people with their hands raised, and so what we'd like to do at this time, if that's okay, is allow them to talk and ask their question. And the first person who had their hand raised is Robin Whitehead. So Robin, I am going to unmute you so that you can ask your question directly to Cheryl. Robin?
I think she's still muted.
Yeah, looks like.
Did I unmute myself?
You did that time. There you go.
Okay. Well, I recently had a coworker to have a stroke, which was on her, basically what you talked about, on her left side.
Mm-hmm.
And I think during the time she did have symptoms, but she just overlooked them.
Mm-hmm.
And right now she's in recovery. So what can be done to make someone take heed that these signs and symptoms that they have are real?
Yeah. Well, Robin, I appreciate your question, and I'm very sorry to hear about your coworker. I hope she does well. the best thing is word of mouth, and, you know, coming to these lectures, you guys spreading the word out. We all, the stroke coordinators, there's 3 coordinators at Baptist. We try and speak regularly to get the word out to people. But sometimes you just can't make them go. But you got to get the word out to people and let people know that we're there and it's for real, that it's something going on. You're not right. Uh-oh.
It's okay.
You guys,
we can hear you now.
Okay, I'm sorry.
Sorry.
I was saying that you got to get the word out to people and let them know that it's something real happening, that it's just not going to go away. And coming to these lectures and to people that you know, and making sure they understand that, you know, it's just something real. People just don't think it's real sometimes. If stroke had pain, so the biggest thing why chest pain and heart attack got treated so quickly over the years is because of the amount of pain you have with that. There is no pain with a stroke. Very, very rarely, like 1% of the population that I've seen has pain with their stroke. So they don't think it's real. That's why we just keep trying to get the word out to people that, you know, what the symptoms are. And if you have these symptoms, you got to come to the hospital.
And of course, she was a woman.
Yeah, yeah. Well, I hope she does well. And does she have family around her or somebody taking care of her?
Yes, she has family. She's
Okay.
coming along very well. Thank
Good.
you.
Okay. Uh-huh.
Thank you, Robin.
You're welcome.
We have another hand raised in our audience, Miss Vivian Missouri. And Vivian, we're going to unmute you so that you can ask your question to Cheryl. Go right ahead.
I think she's muted.
Vivian, will you unmute yourself so that you can ask your question?
My hand was not raised.
Okay. I'm sorry about that. Okay, no problem at all. No problem at all. Do we have any other questions from our audience at this time? Okay, I do see one. Yvonne Walker. Yvonne, if you unmute yourself, you'll be able to ask your question.
Can you hear me now?
Yes, ma'am.
Can you hear me? Okay. Now, I was on aspirin because I do have high blood pressure and AFib. And I've heard a lot of talk now that you really don't need to be on aspirin.
That is a medical decision by your physician. There are some studies that talk about aspirin and not taking it regularly. Those were due to people that have high bleed tendencies, like they had ulcers and the aspirin they aggravated it. So if you're on it, don't ever stop it unless you talk to your doctor, especially since you have high blood pressure. You know, that's a conversation for you and your physician to talk about.
I'll be taking it then.
Yeah. Does that tell me you weren't taking it there for a little while?
I still take it, but sometimes, you know, when I get up, I forget. But
yeah, I know. But yeah, you got to take those meds as they're ordered. And again, if you're going to stop something, talk to your doctor and, you know, see, maybe it's not making you feel good. Maybe you are having some bleeding tendency, a lot of bruising or bleeding in your gums or things like that. But that risk outweighs, you know, not having a stroke. So that's
Amen.
Yeah.
Thank you.
Yes, ma'am. Thank you.
Thank you, Ms. Walker. We do have another hand raised, Lillian Holloman. Lillian, I'm going to unmute you, and if you'll ask your question. Lillian?
All right, can you hear me now?
Yes, we can.
Yes, I don't have a question, but I just want to thank you for the information, which I had a family member to pass away a year ago this month. And she had her first stroke in 2016. And it was so severe, the doctor said that she would never be able to stay alone. And by the grace of God, she was able to stay alone in her own place for 5 years. And she passed away a year ago this month. And a stroke, I want to reinforce what you said. It is real, very real. And I just want to thank you for the information, because I think, like you said, it's a lot more of us need to listen and get information and listen to their bodies and follow the protocol. I just make sure that I try to eat right, exercise, and listen to my body as to what's happening each day. I thank God I'm 70 years old and I'm still able to walk up to 4 miles a day, and I try to eat right. But I just want to thank you very much.
Oh, thank you, Lillian. And I'm glad. You sound like you're on a wonderful track to see 80 and even 90, if I know anything. I'm very sorry about your friend that had the stroke.
It was my sister.
Oh, your sister. I'm sorry. Yeah, but I'm glad she got to live by herself then. She must have recovered quite well.
She did. She
You
did
saw
real
that
well.
recovery, I imagine, and how much it took to do that.
Yes, yes.
Yeah. Well, thank you. And I did want to tell the audience that the stroke coordinators are always available to speak at churches and events that you might know of. If just get in touch with Lynn and her group, and they can schedule us to speak. You know, we kind of talk about the same thing, but we say the same thing because it's really not changing yet out there.
Yes.
Everybody's getting the message. So we're available if you need a speaker somewhere. So
thank you. Thank you very much.
Well, that's fantastic. A lot of good questions, very good questions and very good thoughts. And thanks for sharing those, ladies. And if you, anyone else has any questions, just raise your hand and we're happy to unmute you so that you can ask your question to Cheryl of Cheryl Now. I do see a hand raised by Mr. Kenneth Emanuel. So I'm gonna unmute you, Mr. Emanuel, so that you can ask your question, and go right ahead. You're on mute.
is he still on mute?
Yeah, he's still on mute. You're on mute if you're trying to speak with us. And if there's anyone else who would like to ask a question, please raise your hand and we will be happy.
Yeah, can you hear me now?
Yes, we can. How are you this evening?
I'm doing fairly well, thank God. I want to say thanks to the speaker and to you and all involved. I had a stroke on 9 December 2018, a date that lives in infamy for me, but I'm doing well. I have a little bit of a technical question, and I might fumble this a little, but I wanted to get another opinion about. My stroke was not related to high blood pressure or heart-related issues, but the best opinion that I received after a lot of evaluation, et cetera, and sleep tests was that I had a very mild form of sleep apnea. And over the years, doing deep sleep or REM sleep, I apparently lost oxygen so many times an hour. And as a result of that, it was a shock to my system. And amyloid protein that was supposed to flush out never did, and accumulated in my blood vessels of my brain. And eventually on that day, 9 December 2018, there was a rupture and thus a stroke. I am, as a result of that, at Mayo, I had stem cell treatment, and that all worked out, and went to rehab, and I just praise God for my recovery. I'm on a CPAP now to avoid the problem of unrecognized sleep apnea because I worked throughout my career is pretty busy without any results of sleepiness during the workday or anything like that. So I had no clue that that was a problem at all. Now, my latest MRI showed that there were some black spots that were identified as amyloid protein.
Mm-hmm.
And the reading suggests that some of us in the population tend to have problems with amyloid protein. And I am trying to follow all the instructions about use of the CPAC, watching what I eat and exercise because I'm diabetic as well. So I'm on a regimen to try to give myself the best shot. But I often wonder, could I still have sleep apnea and not know it? And the amyloid protein is starting the same path that it did years ago. And I read something that said if you have one stroke, there's the likelihood to have a second one. And I absolutely don't want to have a second one. So I'm wondering, beginning to wonder whether I should get another sleep test.
Mr. Kenneth, are you still using your CPAP?
Yes, I am. Really?
Okay. And do you get it checked regularly? You know, you have to check those machines every once in a while. How old is your machine?
Not very. I think it's coming up on 3 years, but every year I have to take it in
Okay.
and get a check. And I had one, the last one I had was, I believe, in January.
Uh-huh. Okay. Well, I can tell you, I mean, I can't give you specifics because I can't diagnose over the computer, but you're doing the proper things. You got your CPAP needs to be checked at least once a year. If you are still feeling tired when you wake up, you might need to have another sleep test, or maybe one of your meds needs to be adjusted. Do you see your physician regularly as well, like every 3-4 months? Because you've got some risk factors there, I imagine.
I tend to see my primary care physician every 3 months, which is associated with my A1C and general health issues.
Yeah.
I was supposed to see him on the 24th, but some scheduling problems. They're going to schedule it sometime this week for me.
Okay. Yeah, just you keep, and like I said, read him if you are still not feeling rested, with using your CPAP, maybe there needs to be some changes made to the machine, which would be another sleep study to, even do that. Or maybe one of your medications needs to be looked at. There's several things that we can look at there. And if you've got a good primary care and trust them, then, that's who you need to talk to. And I assume you see a cardiologist for your blood pressure and an endocrinologist, or is your primary care handling all that?
Well, I'm not seeing a cardiology because I've never had any symptoms of heart issues or high blood pressure, but I do take, I see neurologists often.
Uh-huh.
And they do a full workup on me because I am going to enter a Alzheimer's disease and MCI study, which requires routine reviews, both practical testing and medical testing.
Yeah, I've heard there's some new studies coming up. Yeah. Well, if you're not seeing a cardiologist, I might ask, if I was you, ask your primary care about seeing a cardiologist at least once to clear you. Because they do other tests that the primary care would not do. Again,
I will do that.
Tired, it could be related to heart versus, your sleep apnea, blood pressure, things like that. So that's a different specialty to sort that out.
Thank you for that. I will make that. I would ask the question because I rather know than not know, and I want to rule out other issues.
Yeah.
Because I'm not 35 anymore. So.
Who of us is?
Oh, well, I could be if I didn't know so many other people who knew otherwise. So thank you, Mr. Emmanuel. We really do appreciate your question that you asked of the group. And if we don't have any additional questions, I'd like to just take this. I don't see any other hands raised, but I really want to thank you, Cheryl, for a fantastic presentation. And you're just a wealth of knowledge when it comes to stroke. And we will be in touch with you on opportunities to speak to some of our faith partners on this subject, because we realize how important it is that the community understands stroke, and that the community understands the signs and symptoms and what to do to prevent a stroke, and how to identify when they are having a stroke. So we really do appreciate what you've shared with us this evening. So thank you again very much.
Oh,
And
thank you, Lynn. I appreciate being here and letting people listen to me. Thank you.
okay. So we will, Zavanya is going to share some announcements with us at this time. Zavanya?
Yes, hello. Thank you so much again, Cheryl. Yeah, that was, wow, very, very thorough. Really appreciate you taking the time to be with us here tonight. I do have a few very brief closing announcements. There is an electronic takeaway handout that will be emailed to all of the registrants on tomorrow. So once you receive that, please feel free to share that. And it does have all of the information in a synopsis form that was shared today. Also, there is a very brief survey link that we will be sending out tomorrow as well, just so we can get your feedback about tonight's session. Your feedback is invaluable to us so that we can continue to bring information in sessions like this that will help. We definitely want to be able to bring to you information that you want to know about. So your feedback is very, very appreciated. Also, next month, we will be revisiting the topic on falls prevention that was postponed back in April. So for the month of June, we will be sharing a special documentary entitled Saving Claire, which is produced by Ames Production Company. We'll also have live expert panelists there to answer any of your questions. I would like to say particularly, this is a very important session for seniors who live alone, as well as for caregivers of seniors. So if you or someone fits these descriptions as far as being a senior or being a caregiver of a senior, we highly, highly encourage you to register to attend this session. It is a very engaging and as well as entertaining documentary. So please join us, and please share and spread the word about it. All are welcome to attend. Lastly, please take note of the summer sessions or for the remainder of the summer, the sessions that we have already confirmed. So Dr. Foy will join us in July to discuss diabetes. And in August, 3 of our community partners will join us to talk about nutrition and the services that are available in our area to promote healthy, affordable eating. So please save those dates, July 26th for diabetes and August 23rd for our nutrition session. So that ends tonight's session. Thank you so much again for joining us, and we hope to see you next month. And please, please spread the word. All right, good night, everyone.